Hey, good morning, everyone. Welcome to the webinar organized by the Faculty of Medicine, UKM. This webinar is organized by the Faculty of Medicine. It is an initiative of a faculty to reach out to the community. For your information, today's webinar will be conducted in English, and the topic for today's is it important to examine the placenta? So before I start, I need to mention that there is some real images of placenta, and for those who aren't not comfortable with blood and tissue, I suggest you should log out or discontinue now. I see somebody raise up their hand. So for those who have questions, I suggest that you put your question in the chat or Q&A, and I will respond to your questions at the end of the sessions. So yeah, so all three participants has raised hand, but if you have any questions, please put your question into the chat or Q&A sessions, and I'll try to respond to your questions at the end. Hope that's all right. Okay, so placenta is a very interesting tissue topic. We know that placenta play a very significant role in our life. It's actually very crucial to our life, especially in the early 9 months of our life. And without it, we cannot survive. However, many of us pay very little attention to it. So over in these particular sessions, I want to convince you that placenta is actually an important organ that we should pay more attention to. So going to the next slides, I think maybe the picture is huge, slightly slow. Okay, so placenta has many names. One of the interesting name that has been given to placenta is the baby's first roommate. So literally, placenta is actually the roommates of the baby. So placenta has been with the baby for the first 9 months of everyone's life, together with the baby in the uterus for 9 months. Therefore, it should be baby's first roommate, or everybody's first roommate. And it is also being named as the guardian angel of the baby, best friends, companion, early life companion of the baby. And for a placenta or a pediatric pathologist point of view, it is the diary of pregnancy. Why we call it as a diary of pregnancy? Because it basically records all the events, or not, if not all, at least some of the events that has happened during the pregnancy. Taking for example, if the mother have hypertension, let's say, so what will happen is that if you examine the placenta, you'll be able to see changes in the mother's blood vessels or the maternal blood vessels. The blood vessels will be thickened, and what we call as acute atherosis. What happens in acute atherosis is that the maternal blood vessels become thickened, and there is fibrinoid necrosis in the wall of the blood vessels, and that blood vessels actually become less elastic, and therefore can lead to a lot of complications. So we'll be able to see all these changes by examining the placenta and tell that how severe the hypertension the mother is having. Another example would be if there is reductions in the amniotic fluid in the uterus. So a condition known as oligohydramnios. And when there is oligohydramnios, what happens is that the baby will, the placenta, the baby will all come into very close contact and causing frictions. And because of the friction, it developed nodules on the placenta surface. These nodules are actually fibrin nodule. Fibrin nodule is actually clotting materials. And these leave behind sign and telltales of something has happened during the pregnancy. So therefore, we like to call this as the diary of pregnancy. So in this about 45 minutes or so, I will go through some of the topics, for example, like the anatomy and functions of the placenta very quickly, and then quickly mentions what can be achieved by evaluating the placenta. And the major bulk of this particular talk will be on what abnormalities can be seen in the placenta. And then subsequently, what is the indications or when is it necessary to examine the placenta? And finally, give you a brief summary on the whole topic. So look at these particular pictures. So the placenta is basically a disc-shaped structures with an umbilical cord attached to it. The placenta has two surfaces. So this one is the fetal surface. Fetal surface is where the umbilical cord arises. So this is the umbilical cord. So umbilical cord attached to the fetal surface. And you have the other opposite side would be the maternal surface. The maternal surface has multiple cotyledons or lobules. To be exact, there are about 15 to 25 of these lobules. Each lobule represents a blood supply by the fetal stem vessels. And you have also fetal membrane. Fetal membrane is the sac that covers the babies and the amniotic fluid. So a bit about the parameters of the placentas. So the placenta is about 2 to 3 centimeter in thickness, 20 centimeter in diameter. So a lot of 2 and a lot of 5 actually. So 2 to 3 centimeter in thickness, 20 centimeter in diameter, and 500 grams in weight. And the umbilical cord is about 1 to 2 centimeter in diameter and about 50 centimeter in length. So the number is all about 2 and 5. So next I want to bring you to the development of the placenta. So placenta actually can be thinned as early as about 6 to 7 days after fertilizations. So at this stage, the fertilized ovumes will develop into a blastocyst. So this is a blastocyst, which consists of a layer of trophoblast flattened cells at the periphery. And within this cyst, there's a clump of large cells known as the inner cell mass. The placenta is formed from these trophoblasts, the outer flattened cells. This trophoblast eventually forms the placenta, whereas the inner cell mass, which is this one, this is the larger cells, eventually forms the embryos and go on to develop into fetus and a baby. So inner cell mass is the pluripotent cells. Sorry, my cursor is missing. So inner cell mass. I think someone raised hand again. So I think I will leave all the questions towards the end. Thank you. So inner cell mass eventually forms the embryos and fetus and baby, whereas the trophoblast forms the placentas. And this is a picture of a real blastocyst. So though this picture is very busy, I just want you to concentrate on this particular day 5. So day 5 to day 7, as I mentioned, is where the blastocyst starts to appear. And these yellow color cells are the trophoblasts, and the red color cells are inner cell mass. And what happens is that, fast forward to day 23, the yellow cells eventually develop into the placenta. So this is the placenta and the chorion. Whereas the inner cell mass, the red color cells, eventually develop into the fetus, the embryo, and the amnion. And the amnion and the chorion here eventually forms the fetal membrane. So fetal membrane has both the fetal component as well as the trophoblast component. So this, everybody knows this already. Placenta is a multifunctional organ. It's an organ that's attached to the uterus during pregnancy, linked to the baby by the umbilical cord. And basically, it produces the functions of passing oxygen and nutrients from the mothers to the baby and remove waste product, and particularly carbon dioxide, back to the mother through the umbilical cord and placentas. So in this picture, here is a placenta, and this is the umbilical cord. So it supports the growing fetus. And the other thing that we now know is that it is also a storage of stem cells. Many people have now looked into whether we can harvest stem cells from the placenta to be used for diseases, particularly in young children or neonates. So as I mentioned to you just now, placenta is made out of 2 parts. So parts of it are from the baby and parts of it are from the mother. So placenta from the baby will be the fetal membrane and the umbilical cord. And from the mother is the decidua. Decidua is actually a conversion of cells during pregnancy from the endometrium. So something to give a thoughts on is that although placenta play an enormous role in the developing fetus, however, after delivery, what happens is that we celebrated the birth of the newborn, and little attention is paid on the placenta, and it's often just discarded without doing much on it. However, in this particular short 45 minutes or so, I want to bring to your attention that this placenta provides a lot of information on the well-being of the mother and newborn. And therefore, if there is indications to examine the placenta, it should be examined. So as I mentioned earlier to you, it provides a glimpse to the events that can occur during pregnancy. For example, the hypertensions, the oligohydramnias, and many others. So in short, what can be achieved by the examining the placenta is that it can explain stillbirth. And it can predict possible recurrence in certain conditions, like for example, the maternal floor infection, which is actually a lot of deposition of fibrin in the placenta, can actually be recur. So if we know that the cause of stillbirth is due to maternal floor infections, then we can be produce a guide or an awareness of we should be looking into this problem in subsequent pregnancy. It can identify problems that needs immediate care of mothers and baby, in particularly such as infections. We can even grade the level of infections, and whether the infections affects the maternal sites of the tissue or the fetal side of the tissue, and that will determines our subsequent management. It can also identify possible future long-term disability, for example, cerebral palsy. Cerebral palsy is a form of weakness due to a problem in the development of the brain or a damage to the brain due to ischemia. And if there's a blood clot in the placenta, that could be a reason for the ischemia of the brain and causing cerebral palsy. So by examining the placenta, we will be able to identify whether there's a blood clot or not. So stillbirth is no signs of life upon delivery. It's a devastating situation to be in. However, it should be properly investigated in order to prevent any recurrence in the future. So we now know that through many studies, about 1/3 of stillbirth are due to placenta abnormalities. 57% due to infections, and there are other reasons as well, like for example, delivery or labor complications, or other maternal medical conditions. So there's a study looking at about 100 stillbirth, and they look at the value of examinations of the placenta alone, value of examinations, the autopsy alone, and in combination, whether how many percent eventually can determine the cause of that, or the cause of the stillbirth. And they found that about half of the cases, by examining the placenta, you'll be able to identify the cause of the stillbirth. And then if you look at it, it's even better than doing a post-mortem. So by looking at the placenta alone, you'll be able to tell half of the cause of this stillbirth. And if you do both a post-mortem as well as a placenta, and the chances of identifying something is up to about 70%. Okay, next I want to show you some of the abnormality that can happen in the umbilical cord. So a multi-center study shows that stillbirth can be due to only cord abnormalities in about 7.8 to 28% of the cases. So the picture on your right shows an umbilical cord in the center. It has 2 arteries and 1 vein. So what's the type of abnormality that we can see in the umbilical cord? So it can be called abnormality in the length of the cord, the coil, meaning the twist in the umbilical cord. I will show you how it looks like. There can be a formation of knots. Can be a constriction or stricture. This is rare. However, some studies have shown that stricture of the umbilical cord can be recurrence. It can be due to amniotic band. Amniotic band syndrome is basically if there is an injury in the amniotic sac and scar begin to form, and this scar go and encircle parts of the umbilical cord, can even encircle parts of the developing fetus. There can be abnormality due to the insertions. So I'll show you insertion of the umbilical cord is usually in the central part of the placenta or the paracentral. However, it can insert into some other places and leading to complications. So the length of the umbilical cord is about 50 centimeters. To be very exact, 50 centimeters around at 30 weeks and 60 centimeters around at 40 weeks. When it is less than 35 centimeters at term, not preterm, at term means above 37 weeks, then we call it a short cord. So the 35 centimeters has to be examined the entire length, including the length that is left behind on the fetus or on the baby. And shortcut can be seen in condition where there is reduced fetal movement, like for example, Down syndrome. Down syndrome is a genetic disorder where there is a 3 chromosome or trisomy of the chromosome 21, skeletal abnormalities, uterine malformations. So why do we need to know that? That's because it can lead to some complications. Due to the traction, because of the short cord, it can lead to premature separation of the placenta from the uterus. And this is clinically known as the abruptio placenta. What will happen is that if there is abruptio placenta, it can lead to bleeding and can lead to stillbirth or intrauterine death. Other thing that can happen is cord rupture, bleeding, or prolonged labor. If it is more than 70 centimeters at term, we call that as long cord. Long cord can be associated with entanglement. Entanglement means, like for example, cord around neck, prolapse, constrictions, and hypercoiling. I'll show you what I mean by hypercoiling in the next slides. What's the complications for long cord? It can lead to fetal distress, neurological abnormalities, reduced growth, and fetal death. So I think so someone raise hand. Is it because you cannot hear or you have a question? If you have a question, I would suggest you put that question in the chat, please. So for those who lived through the 1970s, you'll be able to remember that the telephone looked like this. So it has a cord that attaches the phone handle to the main dial, and the cord has this coiling thing. And the main reasons for the coil is that you're able to pull and reach out as far as possible. If there is no coil like this, then the movement is going to be very restricted. Same thing happens, same thing for the umbilical cord. The coiling is supposed to make the umbilical cord more versatile and more able to stretch out and supports the blood vessels that is within it. So if there is no coil, any tractions will actually occlude the blood vessels within. So normally in every 10 centimeters of the umbilical cord, there should be around 1 to 3 coils. So we have this cord coiling index, which is number of coils divided by the length of the umbilical cord. And the coiling index should be around 0.1 to 0.3. Anything above 0.3 coiling index, we call it as hypercoiling. Anything less than 0.1 means hypocoiling. Which means that if you don't see any coil in 10 centimeters, it is hypercoiling. Or if you see 4 or 5 coils in 10 centimeters, then if you see 5 and above, then likely it's going to be hypercoiling. Abnormal cord coiling can be associated with intrauterine death, fetal distress, fetal growth restrictions, admissions to NICU, and infection. So this is two placenta putting side by side. One is hypercoiling of the cord and the other is hypocoiling of the cord. The one on the left is hypercoiling. As you can see, the number of coins is very likely to be more than 10 in 10 centimeter. That will give you a coiling index of more than 1. Whereas in this, if you look at this ruler, is from here until here is about 10 to 14, 15 centimeter, and there is no coil at all in the entire length. So this is known as hypocoiling of the umbilical cord. Both hypercoiling and hypocoiling can give rise to a number of complications like intrauterine death, stillbirth, fetal growth restrictions, fetal distress. The reason, as I mentioned to you, with this too much coiling can also affect the blood vessel, as you can see here, and no coiling also can affect the blood vessels being. Sometimes umbilical cord can also develop knots. This occurs when the fetus is moving through a loop of umbilical cord. Rare, but can happen. The incidence is about 0.2 to 1.2%. And it can, usually it's associated with long cord, increased fetal movement, and male gender. Too much amniotic fluid is another reason. There's two types. We call it as loose knot and tie knot. Tight knot. Loose knot, there's nothing to worry. Like for example, this one is actually a loose knot. However, in a tight knot, complications can occur. It can occlude the blood vessels and causing reduction in blood flow to the placenta and the feet and the babies, and eventually can have a risk of fetal death, prematurity, poor growth, and admissions to NICU. Next, I'm to introduce to you abnormal cord insertion. As I mentioned to you just now, normally the umbilical cord is attached to the fetal surface at the central region or the paracentral region. Paracentral means that, like for example, this is the placenta and this is the center. Paracentral meaning that it is within 5 centimeters from the central region and 5 centimeters away from the margin. So this is the margin of the placenta. So this is the fetal surface. So in this case, you can see the umbilical cord is attached to the margin. When it's attached to the margin, we call this placenta as the battledore placenta. So like this, battledore. Or sometimes people call this as tennis racket appearance. So like this is the string part and this is the handle part. So tennis racket appearance. Or in the placenta pathologist term is battledore. The next one in the middle, you can see that the umbilical cord is attached actually to the membrane, not to the placenta. So this is the membrane, a very thin layer of sac. So the umbilical cord attached to here, and as you can see here, subsequently the vessel starts to branch out, and the branch vessels eventually reaches the placenta. The problem is that these blood vessels are not protected by the umbilical cord anymore. So umbilical cord has not only the 3 vessels, it also has what is known as the Wharton jelly. Wharton jelly is a matrix that protects the blood vessels. So when it's attached to the membrane, it loses the Wharton jelly. And the complications is that these blood vessels can be vulnerable for ruptures and bleeding. And this type of placenta insertion is known as the filamentous insertion. So like this. So filamentous insertion of the cord. And then there's a third type of insertions. On the right here, you see, so even before the placenta reaches the, even before the umbilical cord reaches the placenta, it loses its Wharton jelly. And it started to branch out into vessels. So you can see dangling of these blood vessels in between the umbilical cord and the placentas. And again, this is a huge risk because it can easily get injured and causes bleeding. For example, in this case, you can see there's a lot of bleeding on the fetal surface. And this type of cord insertion is known as the furcate insertion. So this is furcate insertions. So furcate insertions is defined as loss of Wharton jelly with visible branching vessels. So you have three types of abnormal cord insertion here. One is called the battledore on the left here. One is the filamentous insertions into the membrane. And lastly, the furcate insertions, where it loses the Wharton jelly and the blood vessel starts to branch even before it reaches the placenta. This is one case that we have recently seen. This is umbilical cord stricture. So you can see here, the umbilical cord is inserted in the paracentral region. However, it has multiple constriction sites. This is one site, and this is another one. Sometimes you can see quite commonly some amount of constriction near the fetal insertion, near the baby insertion. However, seldom we see constriction that is near the placenta site. And this is one case. So if there is a constriction here, it basically causes obstructions to the underlying umbilical artery as well as the vein. And what happened next is that the umbilical cord that's next to this constriction become very edematous, such as you have seen here, become enlarged and filled with fluid. That is due to the sluggishness of the blood flow in that particular region. So this is rare, but a few studies have shown that it may be a recurrence effect, but we don't know this for sure yet. Okay, this is a case of amniotic band syndrome. As I said, amniotic band is due to some form of injury to the amniotic sac, and what happens is that there is scarring of that particular region, and scarring eventually forms what is known as fibrosis, and this fibrotic band can encircle the umbilical cord, causing constrictions to the umbilical vessels, and can even cause constriction onto parts of the limb of the baby. And in this case, it is around the finger of the baby and leading to amputation of the finger. Very unfortunate case. So the other thing that we can see in the umbilical cord is that the umbilical cord may lose one of its artery, and this is known as the single umbilical artery. So if you look at the picture here, the one below is a normal umbilical cord that has two arteries and one vein, whereas the one on top has only one artery and one vein. How we know that which is artery and which is vein is that if you look at the artery, it has a much thicker wall, whereas a vein has a very thin wall. Usually, single umbilical artery does not cause major adverse events to the baby. However, it can be associated with congenital anomalies, and poor growth of the baby. So if we see a single umbilical artery, the next thing we need to do is to examine the baby in details, and also to examine the other parts of the placenta in details. Okay, there are actually a lot more abnormalities that you can see in the umbilical cord, but those are the one that is more common and something that should be taken note of. So I show some of the more important one. Next, let's look at the, what's the important thing to look at the placenta disc itself. So one of the things that we do is we weigh the placenta. So we know that the placenta weigh around 500 grams at term. If it is less than 350 grams at term, then we call it a small placenta. And this can be seen in hypertension, pro-growth, and infection. And if it is more than 650 grams at term, it can be due to anemia in the mother, it can be due to diabetes, and it can be due to infection. So a huge placenta doesn't mean that it is good. A small and a large placenta both can be associated with intrauterine death, fetal death, stillbirth, and preterm delivery. So putting side by side, this is normal appearing placenta, normal weight, and whereas this one is a placenta that is from a pregnancy with hypertension. And you can see placenta here is a lot smaller, is shrunken. Okay, the next thing that I want to bring to you is placenta infection. A very important things for us to examine. And we have a lot of requests from our colleagues from the neonatology. They would like to know whether the placenta has infection or not, whether it's inflamed or not. Reason is because if there is inflammation, then the baby would have to be taken good care of, possibly even admission into NICU. So the other terms for placenta infection is acute chorioamnionitis, amniotic fluid infection, or infraamniotic infection. And the most common bacteria responsible for this is the group B streptococcal, or GBS. GBS is actually a normal colonizer or normal microbiota in the GI tracts and the vagina of healthy adults in about 20 to 30% of people. Other pathogens that may be involved in chorioamnionitis would be mycoplasma, ureaplasma, Gardnerella vaginalis, and E. coli. So why do we need to know whether there is infections? So it can lead to multiple complications. In the lung, what can happen is that the baby can develop neonatal pneumonia, can develop bronchopulmonary dysplasia. This bronchopulmonary dysplasia is a chronic lung disease with inflammation and scarring within the lung tissue. In the brain, meningitis can occur, as well as cerebral palsy. In the intestines, necrotizing enterocolitis can occur. These infections can even spread to the entire body and causing sepsis. Eventually, can even lead to fetal death. So if you look at this particular chart, most of the intrauterine death due to infections occur in second trimester. So second trimester is around 13 till 27 weeks, and this is the time where most cases of intrauterine death are due to infections. Okay, this is a picture of case of chorioamnionitis. So if you can remember, the previous fetal membrane that you see without infections are actually clear, transparent. However, if there is infection, usually appear very dusky and yellowish in color. So this is a histology, histology of the fetal membrane. The fetal membrane has amnion part and a chorion part, and this is a subchorionic region. And in the amnion, you have amnion epithelium, and then you have amnion mesenchyme. And in the chorion, you have chorion mesenchyme. When there is chorioamnionitis or placenta infection, first the neutrophils or the acute inflammatory cells starts to appear at the subchorionic region, and eventually it infiltrates into the chorion, and ultimately it infiltrates into the amnion. So we can grade this into 3 stages. So if it is confined to the subchorionic region, we call this as acute subchorionitis, earlier stage, within 24 hours. If it is infiltrating into the chorion, we call this as acute chorioamnionitis, stage 2, or more than 24 and less than possibly 72 hours. And if you see neutrophils in the amnion together with necrosis or apoptotic bodies, then we call this as acute necrotizing chorioamnionitis. The final stage, stage 3, and it indicates that the infection has been there for more than 72 hours. Okay, the next one I want to bring to you is retroplacental hematomas. This basically means that there is blood clot behind the placenta at the maternal surface in between the uterus and the placenta. And clinically, this is known as a broad-shore placenta. And if this occurs in more than 1/3 of the maternal surface, it can lead to fetal death. The risk for this to occur is high blood pressure, twin, trauma, and advanced maternal age. So this is the maternal surface. The umbilical cord is attached to the opposite side. So we know this is the maternal surface. And over here where the arrow shows is an area of blood clot. So this is a case of retroplacental hematoma or a broad-shore placenta. And the blood, the blood can actually goes into the placental tissue and even cause an indentations to the placental surface. Okay, so the placenta normally implants to the uterus. However, this also can sometimes goes wrong. So normally the placenta is attached to the uterus and is separated by a layer of decidua. However, if the decidua is lost and the placenta is attached directly onto the myometrium, which is the muscle part of the uterus, we call this as placenta accreta. And it becomes very stuck to the placenta and very to the uterus and very difficult to separate from the uterus. If the placenta invade into the myometrium, then we call it as placenta increta. And lastly, if the placenta invade through the uterine wall and goes up to the serosa and can even cause perforation of the uterus. We call that as placenta percreta. What's the risk of this to happen? One is previous abortion, 2 previous cesarean sections, and 3 advanced maternal age. What's the complications? It can lead to retained placenta, bleeding after delivery, and ruptured uterus. What about what is known as the twin-twin transfusion syndrome? Twin-to-twin transfusion syndrome. This is the complications that can occur when there is a monochorionic twins. Monochorionic means that one placenta with 2 babies. So there is also what is known as the dichorionic twins. Dichorionic twins is both twins have 2 separate placenta. Monochorionic twins is 2 babies share the same placenta. So when this occurs, when 2 babies share the same placenta, sometimes, rarely, what can happen is that the blood supplies that goes to one baby also goes to another baby. And let's say in this particular picture, what happens is that the blood supplies that goes to this baby is now being shared by this baby. So this baby becomes the recipient, whereas this baby is known as donor. And it can give rise to a discordance in the growth. Like this baby is a lot bigger than the donor. So by examining the placenta, we'll be able to tell whether this has occurred or not. So what we can do is we can inject dye into the umbilical vein and the umbilical artery. Like in this case, we inject yellow dye into the umbilical vein, and we inject red dye into the umbilical artery. And we can clearly see which is the artery and which is the vein. And this is a monochorionic twin. As you can see, there's one umbilical cord inserted here, and there's another umbilical cord inserted here. So, so if the anastomosis of the blood vessels is between vein and vein, nothing will happen. If the anastomosis is between artery and artery, also nothing will happen. This twin-to-twin transfusion syndrome will occur if there's a anastomosis between vein and artery. So why? That's because the artery has a much higher pressure, and therefore transmit all the bloods from the artery to the vein. Like for example, in this case here, so we know that this is yellow. This is a vein that is coming from this part of the baby, whereas here we know this is red, this is artery. So there's a communication between a vein from this baby and an artery from this particular baby. So this will be the donor baby, and this will be the recipient baby here. It's a close-up view of the anastomosis. In the last few slides, I will show you sometimes tumor can also occur in the placenta. There are 2 main types of tumors in the placenta. One is called the non-trophoblastic tumor, and the other one is the trophoblastic tumor. Non-trophoblastic tumors are very uncommon. The 2 main types is chorangiomas and teratomas. So what you have seen here. Chorangiomas is basically benign tumors of the blood vessels. So in this picture, you can see here, there's a well-circumscribed lesion here. This well-circumscribed lesion is actually a chorangiomas. If it is small, it doesn't cause any harm to the baby. However, if it is more than 5 centimeter or it is multiple, it can lead to intrauterine death and other adverse events. Teratoma is another very uncommon tumor that you can see in the placenta. This is one that we have seen in the year 2008. Basically, this particular tumor grows together with the baby. The baby survives, born normally. However, there's another tumor that developed together with it, and this is a teratoma. And it consists basically a mixture of mature tissue, like for example, fat tissue, smooth muscles, and brain tissue, and so on. So the next one I want to show you, this is a trophoblastic tumor. This is a tumor that is related to pregnancy, and it's due to genetic error occurring during fertilization. So this hydatiform, hydatipsia, basically in Greek means a drop of water. And this particular tumor is very common in the Asian country. It's 10 times more common than Western. So just to give you a brief idea of how these hydatiform moles form. So basically there are two main types of hydatiform mole. One is called complete mole and the other one is the partial mole. Complete moles occur when the sperm fertilizes an empty ovum. No genetic material from the maternal side. And eventually, so either two sperm with an empty ovum developing into a diploid chromosome, or one sperm fertilizes an empty ovum and this one sperm eventually duplicate to form a diploid genetic material. A partial mole is when two sperm fertilize an ovum, giving rise to a triploid genetic material. So in general, we know that complete mole is diploid and partial mole is triploid. So with that, using fluorescent in situ hybridizations, we'll be able to distinguish these two. Although there are other methods or ancillary techniques like immunohistochemistry that we can use to differentiate between complete mole and partial mole. Fish or fluorescent in situ hybridization can also be used. So on your left is a case of complete mole, and on your right is a case of partial mole. So we use this in situ hybridizations technique to identify chromosome 11 and chromosome 16. Chromosome 11 will pick up green signal, and chromosome 16 will pick up red signal. And in this case, you can see two green signal and two red signal, meaning that this is a diploid. And we also did on the X and Y chromosome. And you can see here there's two green signal, no red signal. So this is an XX chromosome. Whereas in the partial mole, we know that it's triploid. So the same thing we did. There are three green signal, 1, 2, 3, and 3 red signal. So there are 3 chromosome 11 and 3 chromosome 16. And when it comes to chromosome X and Y, there's 3 chromosome X because there's 3 green signal. So we know this is a case of partial mole and this is a case of complete mole. So why do we need to know about this hydatiform mole? Rarely in a few small percentage of cases, it may actually develop into choriocarcinoma, a malignant form of trophoblastic neoplasms. And if you look at this case, this choriocarcinoma has already invaded the entire uterus. So coming to the last few slides, just want to mention to you, when do we need to examine the placenta? So we can divide this into 3 categories: related to mother, related to baby, and related placenta. So if the mother has hypertension or diabetes, fever during pregnancy, deliver earlier than due date, very little amniotic fluid, multiple previous miscarriages, then you should examine the placenta. If the baby is stillbirth, too big, too small, appear to have some malformation, monochorionic twin, you should examine the placenta. And if the placenta looks abnormal, too small, too big, the umbilical cord is too short or too long, or there's blood clot in any parts of the placenta, then you should also examine the placenta. You can actually go to the CAP guideline, the Canadian American Pathology Guideline, to look at the entire list of indications. So in summary, placenta examinations provide insight to the well-being of mother and baby during pregnancy. It should be examined if any of the mentioned indications is identified, and examinations may help to assist management and prevent future recurrence of disease. And one thing that should take note is that placenta should be examined in total rather than in portion to avoid missing information. As you can see, a large proportion of the diagnosis can be made just by looking at the placenta grossly, not even looking at the histology. So I didn't really talk about the histology. Histology also play a very significant part of the examinations of placenta. So the take-home message for this particular session is that after delivery, you should ask your doctor about the condition of the placenta, but leave it to your doctor to decide whether it should be sent for further evaluation. Okay, thank you very much. I will now go through the question and see.
Doktor boleh nampak soalan dekat Q&A?
Saya sekarang sedang tengok.
Do you want me to read it?
It's okay. I'm going through now. So thank you, Dr. Kari. So one of the questions put up was how short cord will cause prolonged labor. Okay, very good question. So both actually short cord and long cord can cause prolonged labor. Okay, a short cord meaning that it won't be able to, baby won't be able to stretch and go down to the lower part of the uterus and cause dilatation of the cervix, and therefore it will not so easily give rise or initiate labor. So I hope that answers your question. The next one is, okay, does COVID-19 affect a pregnant woman's placenta? So far, we don't know this very well yet. So as you know, COVID-19 is a very recent event. So people are now looking into this. So a lot of investigations are looking into this, and only a very small number of people have looked into this, and therefore we don't know in detail how COVID-19 affects the placenta at the moment. Okay, another question was very good questions. Do we have any new references for placental weight chart in the Asian population? So as you have correctly pointed out, the chart currently we are using is from the Western country. There's actually no reliable, as I may say, weight chart for Asian population yet. And it's actually high time for us to develop one. Okay, hold on, and I'm just going through the chart. I will come to the Q&A in a while. Okay, so there's another question saying that can certain drugs or medications affect the placenta and the umbilical cord formation? So we know that certain drugs can actually cross the placental barrier and affects the baby. But drugs affecting the placenta umbilical cord, I think there could be drugs that can affect the placenta. Because there are placenta itself can produce hormone, that can affect the baby. So I think there could be drugs that can affect the placenta, but cannot be very certain of this. Okay. Okay, so there's another question. Is it possible for 2 previous cesarean sections have a normal delivery? So normally, this question, probably I'm not the expert in this area, but normally is if there's 2 previous cesarean sections, your obstetricians might advise you that probably it's not a good idea to go for a normal delivery because the uterus may be weaker already. However, having said that, it's better to ask your obstetrician rather than the pathologist. Okay, another question is that HER2 is a surrogate marker for triploidy. What is your view using it to differentiate between partial and complete mole? Okay, this is a very interesting question. So you know a lot on the genetics of HER2. That means I personally don't know how to answer this, but it's definitely a good thing to look into. Definitely a good thing to look into. So the next question is there any possibility of having multiple placenta instead of one in a single gestational period? So I think this is a very unlikely situations to have multiple placenta in a single gestation. Very unlikely. But having said that, sometimes anything can happen. In what situations? I'm not sure. But very unlikely. Usually one placenta in one single pregnancy. or single gestation. Although you can have something like a abnormal placenta, like a bilobe placenta, but multiple placenta, unless it's a twin pregnancy, is very unlikely. Okay, thank you. Another questions from the audience. Does placenta with placenta previa has different condition with normal placenta? So placenta previa is more of an obstetrician question again, but placenta previa is basically a low-lying placenta, meaning that the placenta can actually cover the cervical os. Cervical os is where the baby deliver site, and if the placenta covers, it will not be, the baby will not be able to deliver normally, and that can even cause severe postpartum or hemorrhage. And and the placenta previa, the placenta itself can actually be normal. Okay, and next question is, what pathology in the placenta can be seen in filamentous cord insertion? So as I mentioned earlier, filamentous cord insertion is when the umbilical cord is inserted into the fetal membrane. So when it's inserted into the fetal membrane, into the fetal membrane, the Wharton jelly in the umbilical cord looses, and therefore now the blood vessels are exposed to the external environment, and the blood vessels can actually rupture very easily without the protections from the Wharton jelly. Hope that answers your question. Okay, so I think we have passed the time of 10 o'clock already. Let me see. I think we have passed the clock of 10 o'clock already, and I apologize. I cannot, some of the questions, maybe you can contact me directly and I can answer that. So I'd pass it back to you, Encik Bukhari. Thank you very much. Thank you everyone for attending this particular session.